This is the plan quality review for intact prostate, prostate bed, prostate nodes. We'll get into some prostate SBRT. It's all about prostate today. Same format for the outline, patient assessment, everything upstream of planning that obviously is going to have a big impact on what we do and how we do it. Then getting into simulation, treatment planning itself, that will be the bulk of what we talk about, closing out a little bit on communication and deviations that we should be paying attention to. So let's start patient assessment. Really starting, as we always do, with that MD intent and prescription. This is what drives how we should approach planning. And so as a physicist or a dosimetrist, depending on what your role is, this is where we start to get our information and form the picture of what we're trying to accomplish. Particularly for prostate itself, when we're getting into the background, we really need to understand what is our goal here. Are we just treating intact prostate, which is a much smaller target? It can change our beam angles and a lot of our decisions. Are we treating nodal chains with it? Is it a prostate bed versus the prostate, which may seem similar, but there are subtle differences? Are there individual nodes that are being boosted? All of this information should be in this MD intent and prescription along with fractionation scheme, and we'll get into that in a little bit as well. Just to give an example of maybe where some of those differences fall, you can see on the screen here 3 different situations. The first 2, and if you go by column, so left, middle, right, on the left side we have a prostate bed. So this is where the prostate has been removed surgically. We're doing salvage therapy to the bed itself, and we're treating nodal chains in green, the prostate bed in orange there. And you can see how that's a little bit different from the middle column, where we're treating still pelvic nodes. And for this particular patient, those pelvic nodes go up to a level of about L4. So they're not quite as superior as the prostate bed. That's obviously going to be patient dependent. But the volume of the prostate that's intact here is quite a bit bigger because we're treating the actual prostate itself. And you can see in both of the examples on the bottom row here, we're boosting in the individual nodes. I apologize for the green on green on the left here, but the dark green, it's an individual node being boosted. This yellow region in the middle, individual node being boosted above what the nodal chain gets. And then on the far right is another example of what we might be seeing when we're talking about prostate treatments. This is prostate SBRT, so it's intact prostate only. We're treating a little bit of the seminal vesicles at the superior margin, and then there's this boosted border that's right up against the posterior part of our target, right next to what we'll get into this hydrogel. We'll talk about that a little bit later. So just to get a sense of what we're talking about when we're getting into this prostate lecture. So getting back into that MD intent and prescription, I already mentioned what the volumes are. I kind of mentioned looking into what the intended treatment approach is, but there's a few considerations here. I've already talked about, is it a single target? Are there multiple dose levels where we're boosting it? Is it going to be sequential, which is the more traditional method by which we would have treated nodal chains and boosted to subvolumes such as the prostate or the nodes, where you have to make multiple plans along the way that treat the smaller volumes as we kind of progress, versus more of an integrated boost, which is a more modern approach where we can treat it all in one plan, but now we're controlling different dose levels per plan. And is it going to be conventional fractionation versus SBRT? That can change a lot of things with our dose goals. And getting to those dose goals, again, with the same 3 patients that we saw before, we can see on the left, this is a simultaneous integrated boost where we're treating one plan to all 3 different dose levels combined. So the PTV nodes going to 45 gray, 1.8 gray per fraction. The boosted nodes are going to 55 gray, so 2.2 gray or 220 centigrade per fraction. And then the prostate bed itself is going to 6250 or 250 centigrade per fraction. So all 3 different dose levels, it's one single plan. So different optimization approaches versus a sequential boost, which is what you see here. There are actually 3 different dose levels. So there are 3 different plans. The first is treating everything to in 26 fractions to 4680. That's 1.8 gray per fraction. The next plan, still 1.8 gray per fraction, but we're boosting a subvolume. So we're boosting those individual nodes plus the prostate bed itself. And then these colors are a little bit off here, but we're doing the bed itself going to 70-20. And note that these 2 are both conventional fractionation. If we move to the right, now we're getting into simultaneously integrated boost for prostate SBRT. So this is only 5 fractions, and thus the dose per fraction much higher. And we have the seminal vesicles going to 3625 centigrade, 725 centigrade per fraction. And then little bit higher to the prostate itself, and then that subvolume. Note, total dose lower, dose per fraction higher, number of fractions lower. So all of these are different and viable paradigms when we're talking about treating prostate. All right. And then some other considerations. Are we using contrast? Is it oral contrast, in which case we're thinking about our bowel? I'm getting some feedback here. So if you can stay muted, if you need a question, you can just shout out, but otherwise, please keep it in the chat as well. So we are using contrast. Oral contrast gets us the ability to see bowel. IV, obviously, we get to see some of the vasculature. Is it going to be present within the scan? Do we need to take 2 scans, one with, one without? Because sometimes that higher density then is something we have to account for. We'll talk about that later as well. Bowel and bladder prep are also 2 key components, and I would include bowel with rectum in that consideration. So if we want to have something where we want to have a empty bladder versus a full bladder, well, that can change how much bladder volume is getting specific doses, and it may also change how those particular targets relate to each other. We need to be consistent. We obviously want to have the treatment in the same exact or as close as possible to the same experience from this anatomy at the sim. Is there MPO? How long do we have the patient refrain from eating or drinking prior to sim and treatment? Do they need an enema? All of these are considerations that as physicists, we should be looking for either at sim or even in the treatment planning review process. Some examples of what that looks like. In the left here, we can see this patient has an empty bladder and has had an enema where there's no or very, very limited stool at the distal part of the rectum. And that allows us to be consistent in that treatment. Whereas in this middle section, we can see there's a much fuller bladder where it's pushing much of the bladder out of at least the high dose portion of the field. Okay, moving on to some special considerations. A lot of this is pretty standard. You may have talked about this in previous lectures, but we're thinking about things like pacemakers and ICDs. Obviously, this may impact the energy selection. This, in my previous experience, when we did a lot of these with static field IMRT, this was actually most pertinent for prostate. Super interesting when you don't necessarily think about prostate being a high concern when the patient has a pacemaker, because they're usually really far separated, 40 to 60 to 70 centimeters. However, in our clinic, our physicians really love to use 18X when they treated prostate. And we actually saw the most failures of our electronic devices for treating prostate because of the neutron component of that high energy. So this is still a pertinent subject to be reviewing when you're going into this. Does a patient have these devices, and does that change our energy selection? Implanted hardware, hip implants are definitely coming into play, spine screws, and then we can talk about fiducials themselves and hydrogels. And a few examples of that are this is the same slide as 2 slides ago. Please look at the far right here. We have a hydrogel, and that's that really bright, in this particular patient, very bright anatomy or material within the anatomy located here. And then we have individual markers. In this case, it's high density carbon, so we can align the prostate. The purpose, I'll pause briefly. So in our clinic, for all of our prostate, or basically all of our prostate SBRTs, we use this hydrogel. It is implanted into the patient prior to coming to our clinic, radiation therapy clinic. It's used for 2 reasons. One, it pushes the rectum, the proximal surface of the rectum, farther from the target, so we can drive that rectal dose much lower. So it basically changes the geometry to our favor. And then modern hydrogels, being very, very recently at least, have iodine in them. So you actually can see them very well. This is a challenge, and I'll talk about that in a few slides. Markers themselves, be cognizant of what they're made of. High density carbon is very visible. In the past, you may have higher Z materials such as gold, which is great. You can see them, but they can cause some artifacts that you may have to deal with or also account for that density. This is what I was just talking about with the hydrogel itself. On the left is, for those that have probably using hydrogel, Space OER is a brand name. There are others as well. It may have looked something like this, where it does not have that contrast. And while it can push the rectum further from the target, it may be hard to delineate whether it's in this SIM image itself, or whether it is on the cone beam or whatever imaging you have. But specifically related to planning, it may be hard to say, oh, this is the hydrogel versus this is the target. So it's important that we make sure that that border is well contoured, because if that CTV extends into the hydrogel, we're kind of eliminating the benefit, because our targets then are moving closer but we're treating anatomy that isn't actually patient anatomy that we need to target. So where that border is important for planning, super important for treatment as well. And if you're using some of the new iodinated hydrogels, you can see that very clearly. All right. And then prior radiation, this is kind of standard across anything we do. Patients are living longer, which is fantastic, often multiple courses of treatment. So these considerations come into play, and it changes fundamentally what our expectations are in terms of acceptable OAR doses. So getting into where that previous treatment was, is it overlapping? Is it out of field? Is it in field but further away? All of this is important to know. Unfortunately, we're still in the era where many places have paper charts, so we have to do our best guess even with that information. If there's DICOM available information, that's fantastic. And then patient's anatomy obviously changes. Sometimes these could be years in between. So doing our best approximation of what we're working with, getting that information to the MD, especially if they request to plan some as best we can, and then making sure that the MDs are informed to make the proper decisions. All right, I'll pause briefly here, and if there's any questions. Mara, I don't have the chat open on my screen, so.
No questions in the chat to address. Does anyone have any questions? Dr. Kavanaugh, do you think of the bowel prep differently for SBRT versus standard fractionated prostate? How do you guys handle that?
Yeah, that's a great question. We do actually, and we have two different. I didn't include this in here because it's on trials. It's not a standard of practice yet, but we have a prostate intact SBRT and then a prostate bed SBRT. So we do try to have enemas for all of our prostate bed because that changing volume can really shift the target quite a bit day to day, and it can make it quite challenging for alignment purposes. For intact prostate SBRT, it really comes down to what our margins are. If we're working with very small margins, which we've been moving more and more towards, that variation may be something we want to control. I have some images further on where on one day there's hardly any bowel or any stool in the rectum, and the next day there's a massive amount. And then even over the course of treatment, it can change. And those are the concerns we're thinking about. So longer treatments, smaller margins is something where we definitely want to talk about bowel prep with an enema. Otherwise, no, we really don't control for it in the conventional fractionation paradigm. Bladder, though, we do. We do have instructions for bladder filling that we try to be consistent with.
We have a question in the chat about how oral contrast is handled when a patient has oral contrast at simulation, but not during treatment.
Yeah, it's a really good question. The way we handle it as policy here, and I think everyone does it a little bit differently, but as policy here, we will contour and override it. I think the impact of that dosimetrically is probably quite low. However, it is something that we, as a practice, so we don't have to make determinations between patient to patient, make it as streamlined as possible for dosimetry. We just override any contrast, really. We don't even have a threshold level by which we're applying it. All right, I'll jump into the next section on simulation. So the same format here, starting with patient setup. We have, and I think many, if not the majority of places, have some sort of instructions that are handed off to our sim therapists. Most of this follows standard of practice. However, we still document it on a patient-by-patient basis because you can never fully assume that they're going to be SOP every single time, every single patient. Just really delineates working our way down from what we're treating, what orientation of the patient, what type of mobilization we're using. Is this a full bladder, an empty bladder? I note there's a checkbox there that says rectal balloon, which is much less common these days, but I will have an example of that a little bit. And then the scan length, if there's IV contrast, other contrast needed, what fusions. All of this information is done for us ahead of time in a sim order. And then the day of, or if it's early morning sim, the night before, it is reviewed as in a checklist form directly between RTTs and the physician to make sure that nothing has changed and that we're doing things correctly. Part of that is we want to be as efficient as possible, and we really don't want to inconvenience our patients by having to redo things or have suboptimal information for the sim. Something like this is pretty standard where the patient's supine, arms at and elbows, so arms on chest, elbows up as much as possible. If the physician anticipates having a nodal chain that goes up fairly high into the lumbar spine, we may do arms overhead. That's a little bit uncomfortable for the patient though, so we try to keep it as high on the chest as possible. For us, immobilization is actually fairly limited. You can see here there is this knee cushion for comfort, and then there's this vac lock bag kind of locked into that knee cushion. But note it ends at the knees. So there's really nothing in terms of immobilization from about mid femur up through to the head. And we do that because we found it to be the most consistent and reproducible for the patient. And when they have a vac lock bag around their pelvis that we're treating, it kind of makes a bowl that's oddly shaped. And when they lay down, if they're a little bit off, they don't settle into that same exact spot. So we're seeing a lot of variation day to day. But we also didn't want to have a situation where there's nothing in terms of locking them into place. So having it at the knees, having it at the head really, really helped. And obviously then marking the patient and making sure they're aligned in like a 3-point landing we found to be by far the most consistent. Went too far. And then looking at image quality, doing a full review. Are there any unusual artifacts that we need to account for? Is it maybe some high density materials that need a metal artifact reduction algorithm in the reconstruction? Is the scan range appropriate? Are we getting enough of the OARs with sufficient distance to account for scatter? Is the field of view appropriate? Some patients can be really quite large, or maybe it's, in this case, not as applicable, but there can be lateralized situations. Are we capturing the anatomy? If we're not, if we're clipping, do we have a plan to account for that? On the patient level, for prostate, thinking about things like gas, are there gas artifacts? I've already mentioned the external body clipping, and then slice thickness. And this, for us, at least comes down to modality that we're treating. So if we're doing an SBRT, thinner slices, 2 millimeters is our standard. Standard fractionation, 3 millimeters, a little bit larger slices, helps with a little bit on the efficiency of dose calculation, reduces some scan time, a lot less data to transfer. So getting into that image, the plan or image quality verification, something like this can come up quite frequently, actually, where you can see on the right is what we ended up with. That's why the contours are created on it, where we have this prostate bed. There's obviously a full bladder and a rectum, but the first scan looks something like this, where you have this big air bubble. This patient, unfortunately, they did actually have an enema, but there was gas that was flowing through because that can move faster than stool. And when we took the scan, we see this air bubble. It's one, not reproducible. So we don't want to make our target based on something that definitely will not be the scenario for the subsequent fractions. Two, it's hard to see. Where is the border of the bowel or the rectum versus the bladder versus the target, and for alignment purposes can be very challenging. So getting rid of that transient anatomy, getting something that is very stable and reproducible for treatment. Speaking on variable anatomy, going into a little bit more detail, and I mentioned this earlier, bladder and rectal filling following physician's instructions, gas bubbles adjacent to target, identify as internal anatomy that you're assessing, identify external anatomy, so that's the arm position. Are we out of field, like I had mentioned? And then if they have like something like a colostomy bag, is that bag going to be used during treatment? Is it in the field? Can we move it out of the field so we're not having density in the sim that's not going to be there? And then do we have instructions that's appropriate for the RTTs to know where to place that for the treatment itself? Just get a sense of what some of this looks like in the terms of variation. Full bladder, as I mentioned earlier, can have a big benefit. You're moving, especially if this is the high dose target in pink. If we move a lot of that bladder tissue superior, it's now out of field. So there's a lot less volume going to that high dose or even medium dose versus an empty bladder, which may be more consistent. An empty bladder usually is very reproducible. However, you got more material of the bladder wall within that range of the high dose target. But there's different scenarios that may or may not be important. And then on the right here, you can see an example up above. This patient had an enema. Down below, they actually came for treatment without the enema. This is our prostate bed SBRT program. And it made quite a bit of difference in terms of pushing that target laterally. And there's some nodes that we're treating that we couldn't align appropriately as well. So making sure that we're meeting whatever that physician has asked for. Contrast and implanted devices. I've already talked about contrast a little bit, but in terms of oral and IV contrast, for metal artifacts, I'll spend a little bit of time on this as well. But really, you're asking yourself the question, is this material going to be present at SIM and treatment? Contrast is obviously the one we've talked about. Metal artifacts quite obviously should be present at both if it's an implanted device. And then what are we going to be doing about it? And then moving to the next slide, when we're getting into metal artifact considerations, there are many ways you can approach this, and I've been at several clinics that approach it diametrically opposite, and whether they want to avoid going through that versus going through it and accounting for the density correctly. But a few things to think about here. Number one, do you have the right reconstruction algorithm so you can visualize the artifacts themselves, which you can see down below when we don't use the middle artifact reduction? Very difficult to visualize the anatomy. With using that algorithm, you can start seeing that anatomy quite a bit more clearly, and then making sure that that is the anatomy you want to treat. So right reconstruction, minimize artifacts, but even beyond that, is this material one that is within the range of our CT to density table? Many scanners will start to cap out depending on if it's a 12-bit versus a 16-bit. And so you may see something where you're capping out at about 3,000 Hounsfield units, in which case it could be drastically underestimating what that actual density is if it's something like titanium or gold, and thus you have to consider actually contouring and overriding it. But even beyond that, if even if it has an extended range, is it accurate? And is it accurate depending on your dose calculation or algorithm? So knowing what your HU to relative or even material density, depending on the algorithm you're using, knowing what that is, knowing how that will handle that high density material, and then having some preset rules would be very helpful on when you want to override it and how you want to approach overriding it, what material and or HU to assign it to make sure it's accurate. Sorry, I skipped over one. I already mentioned this one as well to get into those details, but the implanted devices, beware of those high energies. 15 to 18, as I mentioned, we had by far the most failures of implanted pacemakers and ICDs for prostate because we were using that 18, and that changed our standard of practice. And now, since then, obviously better guidelines, Task Group 203 have come out for having institutional guidelines that you can develop to work for your center. And then image transfer, this is just getting information from your SIM-CT into the planning system, ensuring you're using the right CT for your planning. Probably a little bit less applicable if you're only doing one scan in the prostate range. We don't have to worry about a 4D versus the breath hold versus the free breathing. However, you may have situations where doctors prefer to have a few scans, one with maybe full bladder, one with empty, one with contrast, one without contrast. So ensure that we are planning on the correct CT scan that patient was marked on and that will be contoured on. And then I'll kind of just skip past this altogether. This is really not applicable for the pelvis, which makes it easier in this particular sense, but motion management, 4D, there's nothing that's going to be following the respiratory motion consistently. All right, pausing again.
We had excuse me, we had a question about whether you shoot for a super full bladder or whether a half full bladder is more comfortable for the patient. And I think that you mentioned the goal is a reproducibly full bladder, but do you have any suggestions for achieving a reproducibly full bladder?
Oh boy, we've had so many conversations on this topic. So really full bladder, if you only think about dosimetry, sounds great because you're moving all this anatomy far away. So uncomfortable, and we've had so many patients that just can't do that during treatment, and they come back and they have to go to the bathroom halfway through treatment. Now you got an empty bladder, or what is really full varies day to day. So moving away from that, reasonably full is what our goal is. And then you get into the logistics of how do you get reasonably reproducibly full bladders. When it's really important, we actually have preset guidelines of, basically a certain amount of time before. I think we've settled on about 2 hours before, empty your bladder, and then an hour and a half before, drink 8 ounces of fluid. And so we're reducing that fill rate. And so we're getting close to the amount of fluid that we want for treatment. And we do that for SIM and treatment. So those are for our prostate SBRTs. Those are for our prostate bed SBRTs, where the bladder filling is really, really quite important. Even with that, we see variation. It's just limiting the variation. Otherwise, we have those instructions even for conventional fractionation. Typically, changes are the biggest challenge you run into, even with set instructions, is time of day of treatment. So they come in at 8 a.m. They typically have not consumed a bunch of fluid right before that, so there's not a lot of filling. At 5 p.m., they may have had lunch, they may have had a couple coffees, some water, and now that's all over the place. So our therapists also try to do a good job of looking at it and saying, "Oh, you're pretty full. Can you let out half? Can you just let out a little bit?" And then it makes their job a lot harder. So as best you can, if it is important, having some guidelines set up. And by important, thinking about, is it SBRT? Is it high dose in a small number of fractions, in which every fraction becomes really critical?
Thanks, that's very helpful. Does anyone else have any questions?
All right. I'll keep going. Now we're getting into the heart of the material. I have a lot of text on this slide, and I apologize. I try to avoid it, but I was also trying to minimize the over number of slides. So registration accuracy. And I know this is one that you talked about on the other lectures as well. As a physicist, we should be evaluating the accuracy of the image registrations for several intended purposes. Contouring of targets is critical. Ideally, your physicians are also evaluating the accuracy of registrations, because looking at the MR to your CT or PET to your CT is going to determine where the target is. And so having multiple eyes on that is not a bad thing, making it a little bit redundant. But then you get into challenges of, well, my scans are different positions, different times, maybe different days, different internal anatomy combinations. So it can be quite challenging. And then if you have multiple high dose areas, I think prostate plus nodes that we're boosting, maybe one registration is not good for all different parts of the target. So this is kind of the high level approach we usually take. We look at our high dose targets and ensure the registration is accurate for our high dose targets: prostate, prostate bed, nodal boosts. We're assessing alignment to target anatomy when it's possible. If there's a markers, we use those as well. Bony anatomy is kind of our last ditch effort, because a lot of this can move around. And so it depends on proximity to bones. And then consider that impact of uncertainties in the registration. If one registration doesn't work for everything, potentially you may have to copy a data set and do multiple registrations, and then document really well so your physician knows, hey, this is the one that you want to use for prostate contouring, and this registration is the one that you want to use for nodal contouring, things like that. Speaking of contouring, ITV accuracy, again, really not moving, both with breathing motion and ideally not moving even over the course of individual fractions of treatment. So ITV doesn't typically come into extensive play for prostate treatments. However, obviously targets do. And so as a physicist, you should be reviewing the accuracy, completeness, and resolution of all the targets and OARs. It may be, for some people, the target is typically in the realm of the physician. They're responsible for creating it and making sure it's good, which I agree. However, we firmly believe in redundancy. And so we try to build a culture in which physicists can ask questions if something's, even if it's right, but it's different. Asking questions is not a bad thing. Getting that kind of internal conversation with your team. So building that relationship so you can do that. Obviously, we haven't gone to medical school for 4 years and residency for that particular purpose for 5 more. And so what is a CTV and variations amongst is not within our realm of experience. But if you've seen enough of these, sometimes you kind of get a sense of, is it different? Not that it's correct or incorrect, but is it different than what I'm expecting? And those are still important questions. What is in the realm, I'll go back to OARs in a second, but for targets, prostate, prostate bed, nodal chains, nodal boosts, just kind of getting a sense of what those targets are in the CTV level, and then understanding what the margins are. Hopefully your physician will communicate what those margins are expected to be, or even document them, but understanding what your standard of margin is for your clinic is important as well. For OARs, we're talking about rectum, bladder, moral head, sacral plexus, small, large bowel, urethra. And then looking at the resolution of targets and contours themselves. For our case, SBRT targets mean high resolution contouring. So you're just reducing the spacing in between the individual points that make up the peripheral of that target. And it looks something like this, just to get a sense of what we're talking about. Large bowel, obviously to the superior. Now that positioning of that large bowel also can be determined partially on the bladder filling. And so sometimes you can have those really strange situations in small bowel, depending on the anatomy, can come into play as well, where you wouldn't expect large or small bowel to be up against the prostate, but if that bladder is empty, or that patient has weird anatomy, or that loop of bowel sits right on top of the seminal vesicles, something we need to contour and account for. But large bowel, you can see bladder, we've talked about rectum. All those typically should be very visible. The targets usually should be pretty visible as well. What's not visible is typically the urethra. This comes into play within the prostate SBRT paradigm, where we're trying to avoid hot spots in that particular part of the target. And so this is where those registrations come into play, where you can see this on the MR and typically contour it with some sort of margin to best approximate its position. Contour quality, it really is spending some time identifying missing targets. If we say we want a nodal boost in our prescription and it doesn't exist as a contour, maybe it was missed, asking questions about that. OARs and contour quality issues them as well. And this is where, as a physicist, you do and should build some experience with internal anatomy, specifically standard anatomy. OARs are within the realm of what we should be knowledgeable about. But even beyond that, Are we missing interpolations? Are there gaps where there shouldn't be? Are there stray pixels of targets that start to bulge out, incomplete contours, things like that? So I want to work through a little bit of example because all of these so far have been discussed a little bit in individual discrete topics, but they all impact each other. So this is a clinical example where this is my clinic previously, had a patient where the rectum was not contoured all the way to a link to the bowel. So there's a big space here. So you can see in red is the original rectum contour. Way up here is the bowel. This is rectum. It's hard to see a little bit. I'll have the next slide to highlight it, but there's rectum in here that was not contoured. And as you can see, we're treating the prostate and we're treating nodes. And without any contour there, there's no optimization objective then on that tissue, which is highly important OAR tissue. And that caused a bulging of this dose to spill posteriorly and a pretty high level of dose as well. So how do we improve this? We can contour the actual rectum all the way up so it adjoins with the bowel as you would expect it to. Once you make that correct, you can run into this situation where instead of having that mid and high level doses, you can see that green, yellow here is prescription, green is I think 95%. The 95% prescription was spilling into the rectum. We're snapping that back so it only covers the target itself because we've appropriately completed those OARs. I mentioned margins. I'll spend a little bit more time talking about them here. As you're reviewing your contours, if there are margins needed. So obviously targets have margins, sometimes OERs do. I mentioned the urethra often will contour and then add a 2 mm margin around that because we can't see it very well. And it's also in that particular treatment paradigm of prostate SBRT, it's important to make sure we're not getting high dose hot spots in it. There's many others. It's sometimes more important in the realms of other treatment sites, but sometimes OERs have margins. So understanding what your margins are for your institution are really critical. If the MD is creating the targets, so they're doing their own CTV contouring and doing their own margins, they may not specify what those margins are in the directive. I've had clinics where the PTV was the final target, and they didn't feel like it was necessary to say, oh, I want a uniform expansion of 5 mm. And so some of that was we had to understand what the standard of care was for our clinic and verify that it was done correctly. If someone else is doing those expansions, some clinics, the physician will make the GTVs and CTVs, and then, for instance, dosimetry could create the margins. They have to be specified somewhere. Dosimetry needs to know what the expansion is. So verifying that it was done correctly. And either way, you should be looking at this to make sure it makes sense. And there's different scenarios as well. I've had many clinics where the left example is pretty common, where it's non-uniform margins around the prostate. So for instance, some of the most valuable OAR real estate is posterior, the rectum. And so we had rectal margins that were 3 mm, but it was allowed to be higher margins, superior, inferior, and lateral. And so you can see a little bit, in fact, in this case, it was only posterior that was a reduced margin, but it's a thinner margin going from that orange CTV to the green PTV, a little bit larger margin all other directions. You can have uniform margins though. This is the prostate bed, where it was 5 mm in all directions. So knowing what that should be, verifying that's done correctly is important. Looking at external contours and support structures, things like couches, making sure your external is correctly and accurately contoured, confirming that all objects that will attenuate the beam as it passes through are accounted for. Couch overlays are very common, but immobilization devices also can be important. They're either included in the body contour if you're in a clinic where the body contour is what accounts for it, or you may have some external modeling where you're inserting a couch, for instance. And then also determining if any structures should be blocked during planning to avoid passing through that particular structure. And then I mentioned this earlier, but density overrides, this comes into high Z materials if they're going to be present during treatment, contrast if they're not, imaging artifacts if it's something that's transient that was not removed at the SIM. So we may have to account for that density where there may have been imaging artifacts or air bubbles that we know aren't actually physically going to be there for treatment. How do we account for those retrospectively? So some examples of this. On the left here, you can see a patient who are treating prostate. There's a coronal slice. It looks a little bit strange, but or yellow still bladder, Brown is rectum. This bluish one here is the prostate itself and the nodal chain. This patient has a hip implant. So this is a high Z material. I believe it is tungsten. The artifact has been reduced, but it is something that will be there. And so we had to account for it. In our case, we use an algorithm that uses physical materials. And so it had to be assigned in the tungsten for the calculation purposes. It wouldn't even let us calculate without it. Our clinic also, we will treat through hip implants. So we do spend quite a bit of time making sure that we're appropriately contouring and overriding. Other clinics may not. They may just avoid going through it altogether or optimizing on it to avoid fluence, in which case it may not be as critical. On the right here is something that maybe for some people a little bit unusual, for others maybe you've seen it before. This is a rectal balloon. This is from the era prior to hydrogel, where the idea being let's try to get as much of the rectum away from our target as possible. This is in salvage therapy as well. And so you can see this rectal balloon has been inserted at SIM. Has iodine in there that will not be accurately represented as HU. So we had to override that to be effectively water, and then proceed with planning. All right, jumping into some beam settings, unless there's questions that have popped up.
We did have a couple of questions about specifics of PTV margins. There was a question about the posterior margin that you use for the PTV.
It will depend on what part of the target it is. So for instance, nodal chains, 5 millimeters is pretty typical for all of it uniform. If it's prostate itself, we've gone as low as 3, with the exception, and again, I hesitate to even say this, but we have some clinical trials that are looking at 1 millimeter margins for prostate SBRT in very specific circumstances. But as standard, typically 3 millimeters posteriorly is what we're working with. But that also accounts for the fact that we have high quality cone beam imaging, so we can see where that border is, and that at treatment, the therapists are given the instructions to match along that anterior rectal wall. So that is the point that we're ensuring, or at least verifying, is in the correct position, because we know that margin is reduced. I think hopefully that answers the questions. But 3 to 5, I think, is fairly common across the field for prostate.
Yes, and you emphasize the important point in combination with daily cone beam.
Yeah.
And there was one other question about with SIB prostate, what margins you use for the nodes versus the prostate.
Yeah, SIB prostate, assuming we're standing in the conventional fractionation, so 5 millimeters is typical for our nodes. And prostate, it'll be either 3 or 5 millimeters. I've been in many places, so this is where the variation can be doctor to doctor or center to center. But typically left, right, 5 millimeters, and then posterior 3, and then where I've seen the variation is whether they do anterior, sup, and inf at that 5 or something slightly less. Some physicians will also change it kind of patient to patient. If there's bowel that's right above the target, sometimes they'll reduce it a little bit. And then depending on the proximity of the penile bulb, they'll may reduce it from 5 to 3. But I would typically say the rectal is almost universally the smaller margin, and then the laterals are almost universally the larger margin, and the other 3 are somewhere in between those.
And I guess that would be also with alignment to markers in the prostate, right?
Yeah, we'll get into that a little bit alignment topic, but yes, having good alignment is where this comes into play. If you're using MV 2D planar imaging, you can obviously get good markers that you can see and you're aligning prostate, but you have no idea where that rectal wall is, for instance. And so having volumetric imaging in combination with those margin reductions is kind of that key to ensure that we're treating what we need to be treating and avoiding what we need to be avoiding.
Okay, thanks.
All right, thank you. All right, we'll jump ahead here. All right, getting into beam settings. So starting at the top, treatment technique. When I started a decade ago, everything was static field IMRT. In terms of when we did choose IMRT, we've moved heavily into the VMAT world, although even 10 years ago, we learned how to do 3D prostate sequential planning. However, I would say that intensity modulation has a huge advantage for these types of target and OAR combinations. VMAT is something that's a lot more forgiving because of the anatomy, and I'll get into that next slide. We have seen this increase in SBRT, though, for intact prostate only. Getting into beam arrangement, verify the number of arcs or beams as appropriate. This is somewhat subjective. Some general rules of thumb to follow. If you have increasing number of targets, then you may want to think of increasing number of arcs or potentially beam angles. If you have a lot of superior inferior extent of your treatment volumes, then you may want to also consider, and you may need to consider, adding an arc or two, complexity of that target OER relationship. So as these increase either in complexity or a number, that's where we think about adding a few more arcs and or specific beam angles for anatomy. We also want to verify that these angles and trajectories are favorable for target coverage and OAR sparing. And this is where it gets into a little bit of a challenge. So in this particular case here, we see prostate that we're treating. There's a boost inside the prostate itself, and then the blue is the nodal volume. So we're treating up to close to about L4, L5 junction, so moderately long target. We use arcs, and for this particular patient, we had 4 individual arcs, and you can see that they are full arcs, so the full circle, with various collimator angles. This last column is collimator angles. The first 2, almost universally for us for prostate, are just 5 degrees off of 0 for collimator angle, so avoiding a true 0, and then doing some almost full rotation at 85 and 275. These last 2, those collimator angles may vary a little bit between dosimetry as well. And why do we do that? Well, a couple things to consider is having the full arcs, if you have VMAT, is super helpful because depending on where you are in the target, specific angles are more advantageous. This is where also static field IMRT may come into play, but I'll walk through 3 different levels of this particular target. At the superior border right here, you can see that red line goes through where I'm talking. Our target is predominantly posterior, and so these red arrows represent favorable beam angles, but we have small bowel to the anterior. So less favorable beam angle coming anteriorly, not one that should be avoided, but something that in the optimizer will probably weight that part of the target a little bit, or that part of the volume a little bit less anterior beams. Moving down a level though, now we see anterior may be very beneficial for specific parts of the target. Right along midline is some of our critical OARs that we want to avoid: bladder, large bowel loop, kind of looping down inferiorly, rectum. So we obviously don't want dose in the middle moving ant post, but along these long nodal chains, that's really beneficial. And if we come in laterally here, we may be actually going through, exiting, or transitioning across some of those OARs. And then if we go to the inferior part of the target, once again, we see this situation where now anterior and posterior are less favorable, and some of these more lateral or oblique angles are the most favorable. So if we're in the VMAT realm, having full arcs allows the optimizer at each level to determine how much fluence should be coming from those particular directions. If you're working in the static field IMRT realm, I would recommend looking at the full target and not saying, oh, I don't want an anterior beam because it's not beneficial for this particular level. It may be beneficial for other levels, and thus you're giving the optimizer the ability to utilize its skill, its design to figure out fluence at the particular levels, sup-inf of the target and OAR combination. I also want to spend a little bit of time on collimator angle. I mentioned before, we typically have anywhere from 2 to 4 arcs, and then we rotate the collimator angles between them. So I'll show you a few examples of why we do that. This particular patient, this is just intact prostate. So notice only 2 arcs here. So we don't have that long nodal chain. There's just 2 dose levels. Didn't feel like there's a benefit of having more than 2. We have the first arc having a collimator angle of 5 degrees, the second being 90. The reason we chose 90 is for this particular target, that rectum is moving sup-inf. And so having the ability for some leaves from particular angles to come in sup-inf and block out the rectum is something we found to be beneficial. And it's also just adding more degrees of freedom for the optimizer to utilize and how it wants to apply those fluences. Getting some a little more complex though. So this is a very long target. It's moving up to the L4, L5 junction. We're treating prostate and nodes, and then we have this, it's actually moving further inferior than most targets. You can see it actually is clearing most of the S spine. So if we utilize 4 unique angles here, in our clinic, we can see we have 5 degrees, we have 355, and then these 2 are the kind of the diagonal corners are that 85 and 95 angle. One thing to note, I don't have the measurement here, but it was effectively about 16 cm. Make sure I have it. No, I skipped it. 16 cm sup imp. So when you think about your beam geometry, also think about your limitations of your Linacs. This is a variant Linac that we're planning on, so there's a bank limitation of how far MLCs can extend from the individual bank that's set at 14.5 is our rule of thumb. And so because it's 14.5, we may have situations in which there's always going to be some level of opening. But for this length of target, it's going to be very close. And we also have jaw tracking, so that helps us. And so what we did was we basically just kept these as full. We did not restrict the jaws in the X direction for those 90-degree angles. But when you run into a longer target, that's this situation where we're going fully inferior at the superior borders up to that L5, L3, L4 junction. Note it's about 24 cm long. Now that's much longer than the full extension of what the MLCs can do. So we approach this a little bit differently. We have that pretty standard 5 and 355 collimator angle. And then we did a true 90. And we did 190 that covered the superior part of the target and one that covered the inferior part of the target. And we broke that into about that 15 degrees. There's a little bit of overlap. You can kind of see this middle region would be covering both, but that'll make sure that MLCs that aren't needed for putting in fluents at a particular angle can be parked under those jaws. So we're utilizing that particular beam geometry to our advantage for these longer targets. Beam deliverability, this comes into play of you can pick the best angles possible, but if there's going to be something that restricts us from using that, we need to know ahead of time. It becomes less of an impact for prostate because it's a very central target. This is definitely something that's more of a challenge when you get up into, let's say, breasts where it's lateral. But because we're central, our center is typically pretty central, becomes less of a challenge for standard size field of view and or bores. I will say, though, that we've had patients that are larger, especially if they have their arms up above their head, their elbows are way out. Sometimes that can be a challenge. And so you're looking at things like clearance between the couch, the patient, mobilization devices, things like that. Beam robustness, we want to confirm the robustness of the beam arrangement. So avoid angles that may be affected by poor setup or reproducibility, avoid angles that may be affected by variable internal anatomy. And then what to consider for prostate patients specifically, limited impact, again, with a few exceptions. I mentioned the arms. There could be a situation where all of our arms are up, but there can be situations where patients just can't do that. They may have something that restricts their arm coming up altogether and it's down by their side. So that may be something that we either want to avoid that angle or optimize on. Obese patients also can come into play, especially if they're nearing what would be the weight limit for the couch. Sometimes that also very much limits our ability to have field of view issues or even image quality issues. Can we see on a cone beam what we need to see when we have obese patients? And then poor mobilization. Ideally, that's not going to be a case because your team is hopefully following pretty standard practice. But I mentioned right at the beginning that we changed our mobilization to avoid having any right under the pelvis because we were seeing variations day to day for those patients. So thinking about that, if there are situations in which mobilization is maybe made in a way that's not going to be helpful, when you're reviewing the plan and the beam arrangement, how is that something you want to consider? Beam energy, central targets, we typically use 10x or 10 FFF, the FFF being for our SBRT because there's a lot more MUs per fraction. We don't typically go into the high energies, the 15x and the 18x for IMRT, because there's less of an advantage of the beam energy compared when you're controlling the fluents. Conventional fractionation, gantry rotation limits us, meaning that we have fewer MUs per arc, for instance. And so what our limiting factor is in conventional fractionation is the gantry speed. But for SBRT, a lot more MUs. And so that's the advantage of the FFF. And then I think I have, we'll get into an example on the next slide. Last one, modulation factor. So this is largely in the realm of the physicist, and it's a surrogate for before you do your QA, might we run into a problem if we're overmodulating? So verifying your modulation factor, what is that? That's your MU per prescribed dose per fraction in centigrade. For prostate patients, you typically see for intact prostate conventional fractionation, something on the order of 2 to 4 MU per centigrade. That's for VMAT. For VMAT SBRT, it's also about 2 to 4. Prostate nodes might get a little bit higher. if you're using static field IMRT with sliding window, those numbers can be quite a bit higher. So those might be something in the 6 to 10 range for static field sliding window. If you start getting a really high MU per arc, that sometimes is an indication you may benefit by adding an additional arc. So what does that look like? Lots going on this slide. So I'll get into the details here. Two different examples. On the left, prostate node. On the right, prostate SBRT for 5 fractions. You can see the dose levels, 45, 55, and 6250 centigrade over 25 fractions. We used 4 arcs here, roughly about 225 to 270. So on average, about 250 per arc. And that modulation factor, when you do the math, is about almost 4. Here's where it gets a little bit interesting. So if you're using a C-arm gantry, think like a TrueBeam, for instance, this is going to be gantry speed limited. So if we're using conventional fractionation and a 6 or 10x energy, your dose rate is 600 MU per minute, 1 rotation per minute. So your limiting factor there is your gantry speed. So it should be just basically moving at full gantry rotation, but your MU, or your dose rate, may drop quite a bit because otherwise it's not going to get close to, in a minute, it does not need the full dose rate to deliver this many. Ring gantry may be a little bit different though. For instance, a Halcyon can rotate 4 rotations a minute. And so this one might be dose rate limited, where the gantry speed is slowing down and it's maximizing that dose rate. Conversely, SBRT is a little bit different because we use those higher dose rates. This mod factor is 3.3. For a C-arm, still gantry speed limited, 1 rotation per minute and 1400 MU per minute. This one also may be dose rate limited. We're going to get to them. All right, I'm going to jump forward. I'll pause here briefly, see if there's any questions. I know we just went through about 12 slides. If there's no questions, I can keep going.
You can keep going.
All right, thanks. Optimization objectives. This is one of my favorite parts of just planning in general. This is where you get the most variance person to person, which is the art of treatment planning. I am trying to figure out a way to work with our team so we can have a more standard practice while still allowing that flexibility. It is a challenge, but you have to know how your optimization objectives, by looking at them, how that potentially could give you challenges with plan quality. So getting into a little bit here, target objectives. I spend a decent amount of time getting into target objectives and looking at them when I look at plan quality, but really verifying that we have both upper and lower objectives on our targets that we're using to push dose, and that there's separation between those upper and lower objectives. You don't want to give a 1% window that you're trying to thread your prescription dose into, and I'll have a next slide with a DVH to look into that. The other thing that I also consider is the creation of optimization targets. And this is really important for the SIB, or the integrated boost planning, where we have to remove higher dose targets plus some margin from the lower dose targets. And that does 2 things for us. One, well, really 3 things. One, it allows us to control coverage of the lower dose target and the higher dose target, and hotspots that are specific to those dose levels. It also allows us to avoid conflicting dose objectives in the target overlap region, which may then dominate the math behind the inverse optimization, and you could see a consequence inadvertently on OAR doses. So typically objectives, lower dose objectives that I've seen in our clinic are about 101 to 102% of the targeted prescription at each dose level. And then if you're using these SIB optimization targets, upper dose 103 to 105. So you're giving yourself a little bit of a window to work with. I'm a visual person in terms of how I learn, so I want to show an example here of what I'm talking about when we're talking about these optimization targets. So this is a 25 fraction prostate bed. We're treating 2 target levels. We're treating 6250 to the prostate bed itself, and then we're boosting in red to 6750. So same 25 fractions, just different dose per fraction. So they're both having to be optimized and creating the same individual plan. The way we do that is we create the lower dose opt structure. So this is a PTV 6250 opt. So I copy that structure, I crop out the high dose plus 2 millimeters, and it looks something like this down below, where that higher dose PTV is exactly the same. The lower dose PTV is removed from it plus some margin. And thus, I don't have to have, if I didn't do that because they overlap, and I put a hot spot control or high dose control on my lower target, it would reduce coverage in my higher target. By doing this, I can control both independently. And then I optimize on the full PDV 6750 and the opt 6250. And it'll look something like this in terms of the DVH, where the high dose DVH has that nice vertical line. if I were to look at the full target of the low target, it would be the green one where it's pretty vertical, but then in the overlap region, it shoots up to the higher dose. But because I pulled it back, I have that nice vertical blue line here that I'm controlling. And notice I'm only optimizing on the op structure for that lower dose target. All right, so this gets us into our first Zoom poll question. Didn't think I'd forget about these. So I'll read it out. The purpose, this is related to the previous 4 slides. The purpose of target optimization structures for SIB prostate planning includes the following, except control hotspots within the lower dose target, avoids conflicting optimization objectives in overlap of targets, controls for conformity outside of targets, and controls coverage of each target and prescription dose. Remember, except, so you want to find the one that's not true. Mara, I don't know how long I'm supposed to wait until I jump over.
I launched the poll so you guys can start to answer. We'll give you a minute or so to get your answers in. Okay?
All right. Can everyone see the poll? Sorry, I jumped on, interrupted you.
No, I was just saying, can you see the results?
I can. I don't know if anyone else can. All right. Well, I'll move forward on the next slide.
I can see them. I can see them on the screen.
Thank you, Jose. So answer, which is the most responded one, is 3. Controls for conformity outside targets. By separating these, we're basically controlling for all of the other 3. So we're controlling for hotspots within the lower dose target because it allows us to put a optimization high dose control and upper control on that op structure that is below the high dose target. So we can control for the hotspots within the lower dose target. We avoid conflicting optimization objectives in that overlap region where they can't achieve both, so it would be battling itself. And then we also can control coverage for each one independently. So we can do 1, 2, and 4, and the majority of people, about 41%, did select 3. Close there, and we'll keep moving forward. All right, so to get into OER objectives. As physicists, actually, I'm going to make one more point on the target objectives. I didn't write this one down, but one thing that I do as a physicist is I will look at every single structure that has a lower dose objective on it. And this is regardless of prostate. This is standard for any plan. Because if it has a lower dose objective on it, it means it's pushing dose there. And you want to make sure that lower dose objectives were applied to the correct structures. And so obviously that should be targets. Sometimes those are helper structures that if something was a little bit cold, but this is a really fast and easy way to get a sense of my dosimetrist was pushing dose correctly. I see there's a hand raised. It says iPad M1. If you have your hand raised, you can come off mute and say your question. If not, throw it into the chat and we'll grab it on the next section. So OER objectives. One, starting at the top, verifying that OERs have the appropriate DVH and mean dose objectives. They should be somewhat related to whatever the dose prescription or the MD directive was. So making sure that we're, 1, optimizing on all the structures that said were important, and 2, putting in objectives that are similar to what we're trying to control for. Sometimes we need to create optimization objectives and structures. For instance, in our clinic, if there is overlap with an OER with targets, our dosimetrist will sometimes make that OER and split it into 2 independent structures, an OER that's within the target and an OER that's outside of the target. The part that's in the target is then controlled to get prescription dose 2, but not a hotspot, so minimizing hotspots in that overlap region with target OERs. And the part of the OER out of the target, this is where they really drive the dose down as low as possible. Now, there's many other ways you can approach this. So you don't have to do it this way, but this is one mechanism by which you can kind of control the dose to the OERs in 2 different ways. Make sure you're getting prescription still, but driving as low as possible. OER objectives also depend on the fractionation. So if you're working in the hypofractionation or SBRT realm, you're looking a lot at Dmax, some volumetric objectives, but typically you're skewed more towards the high dose controls. Conventional fractionation, volumetric objectives, mean doses, those come into play. It also depends on whether it's a serial or parallel structure in the conventional fractionation scheme. So it might look something like this. This is, again, the 25 fraction example from previous slides, where I have my low dose target op structure. I've got my high dose target itself, which I'm optimizing on, and then I've got 4 different OARs here, and notice that the word out follows after all 3 of them. And as a visual example of that, you can see the rectum here overlaps the green target, the bladder overlaps the green target, but because of this fractionation, I want prescription to the part of the target that overlaps. And so by removing the OAR from that overlap allows me to drive dose down as low as possible to the bladder out or the rectum out while still maintaining that prescription in that overlap region. All right, optimization priorities. This is also very much user dependent. I know I have my own preferences, and even within our clinic, our 5 prostate dosimetrists all have their own preferences. But as rules of thumb, you typically want to have your OAR constraints, your must-haves. So think about serial structures max dose, spine max dose. Those are your must-haves. Those are typically your highest. Your target coverage are the second kind of rank category, and then your OAR goals. This may be either volumetric goals for specific parallel structures, or maybe it is a lower dose, max dose to some of those parallel structures that you'd like to have. You're going to get if the others allow you to. And then you make sure that your prioritizations are weighted somewhat appropriately. So in this case, my rectum out and my bladder out, those are, I like to have those, but those are goals. And so you notice that the numbers are 115, which is a relative number. It doesn't mean anything by itself, but relative to my target coverage objectives of 140, it's saying, hey, this is important, but it's slightly less important. So make sure you're getting your target coverage first for this particular fractionation scheme, and then your rectum out and your bladder out are going a little bit lower. Also note here on these rectum out and bladder out, I've got a upper GUD. So this is a mean dose objective for both of those. And then I've got a volumetric objective. So for rectum, it says 43% of the volume needs to be at or below 30 gray. And then for bladder, it's 36% at 30 gray. Those are a little bit patient determined based on the volume of those structures themselves. And this is where the art, the skill of planning comes into play. Missing objectives, like I mentioned before, investigate the impact of structures that are not included in the optimization. So number one, if it is something in the written directive by your physician, and it's something that they say they want to achieve a specific dose for, it likely should have some objective on it to push dose. It may not have a highly weighted one, but has something. All OARs that are stated there, you need to investigate. If OARs don't have a written directive, look at the dose spillage. Is it pushing dose into something that doesn't need to be pushed into? OARs may be out of field. That's another example. So it may be in the written directive, but it's 8 centimeters superior to the target. Well, then it doesn't really matter. You're just making more complexity to your optimization algorithm. So really that relationship matters too. And as I mentioned before, investigate all structures with lower objectives because they push dose to specific tissue. They should be associated with targets. These, I combine the next 2 bullet points, conflicting objectives and gradient tools. Investigate any conflicting objectives, because if you tell the algorithm to achieve 2 things that are mutually exclusive, they cannot achieve both. It can dominate the solution space, and then you may inadvertently not get dose reduction or target coverage that you could have otherwise achieved. So looking into where those overlaps and those conflicts exist, investigate objectives that were not achieved by the optimizer, give you information such as, oh, we should have cropped the lower or the higher dose target from the lower dose target. Maybe we forgot something like that. Confirm that the appropriate use of integrated planning tools or dose shaping tools such as rings are used and they are created correctly and help to shape the dose. For example, these may be NTO, the normal tissue optimization function. You have these rings, you may have dose fall-off objectives that are specific within either specific OARs or specific directions. These are all shaping tools that control the rate of fall-off. Because the one thing about IMRT is that we know that based on what the priority of OARs are around the target and their proximity to the target, the gradient is going to be different in different directions. So you want a sharper gradient inside OARs that are higher priority. A less sharp gradient may be allowed to get fluents moving to target in the direction of normal tissue and or lower priority OARs, but we still want to control for the dose around the whole target. All right, I'll pause there. We've got about 18 minutes left on our clock, and maybe about 20 slides left to go, but if there are any questions.
There was one question earlier, which maybe we can tie in with missing OARs or missing objectives. The urethra Hasn't always been an OAR we considered, but there was a question about how you visualize or contour the urethra.
Oh boy, yes. So I will start out with, we don't visualize it on treatment. And that is one of the hardest things. There are several ways you can do it with varying levels of discomfort for the patient. Sometimes they can put a tube up through the urethra into the bladder and then have contrast in that tube at time of SIM or maybe at other imaging. And then you can clearly see where it is, uncomfortable for the patient. And also that existence of the tube may actually shift where the urethra is relative to where it is without. Maybe not by much, but we've seen that. We typically will do, just because we will have this anyway, an MR for when we want to visualize the urethra, which is almost exclusively within our prostate SBRT treatments. We'll do an MR. We can clearly, with the appropriate techniques, we can clearly visualize on the MR, and that will be in or close to the treatment position. So we don't have anything disrupting physically the urethra itself. Contour it, and then note it does also just kind of shift day to day. So what we do is, let me see if I can scroll back, because like I said, I'm a visual person. We're getting there. There it is. All right. So on the MR, contour the urethra, and then we will expand 2 millimeters in all directions. And so that gives us it's a PRV, it gives us some ability to say, hey, in this region of the prostate, let's just not allow hot spots here. And so when it does move around day to day during treatment, or if it moves around because we're just making sure that the prostate swelled a little bit during treatment. Okay, well, now I don't know where the urethra is, but it should be relatively close to where we thought it was going to be. No hot spots in that central region. So that obviously requires a different imaging technique, which everyone may not have access to. And so in the realm of prostate SBRT, visualizing it in some capacity in some of the imaging is helpful. And then building that PRV of urethra plus a little bit margin gives us some flexibility to ensure we're doing it safely. Other questions?
There was one other question about if you compensate for a break in treatment with additional dose. I commented that, prostate cancer is generally considered a slow-growing cancer, so a break for a few days is usually okay. But do you have any specifics that you go by or a formula that you use for dose compensation?
We really don't, not for prostate at least. When you get into like the head and neck paradigm, especially with other types of treatment happening concurrently, that can come into play. And then obviously the amount of time of the break is important. But well, there's a couple aspects here. One, we're very lucky to have few scenarios where we get those breaks. Two, we're moving heavily in our clinic, and I know this is not the standard of care, so I'm telling you stuff that may not apply to you, and I apologize, so I'll get into that a little bit, but we're moving heavily into hypofractionation. So trying to reduce, you have classic prostate, which would go to 40 plus fractions, and that's a long time, and you have a higher chance of breaks, especially at the end. So we're moving more and more to 25 fraction for our long course and 5 to 10 for our short course, reduces the chance of break in there. Unless there's basically the patient just disappears for weeks at a time, we won't compensate with additional dose. If they do disappear weeks at a time, it is almost a case by case looking at the BED of how much we delivered. Do they miss one fraction? Were they almost done with treatment? All of those factors come into play. But if it's a few days, or even it's like a week, we typically will just jump back in and start because it is a slow growing type of cancer.
Thanks, that's great. And I can say from my background in proton therapy, if our machine went down, we would let the prostate patients miss a week of treatment before we would send them to photons. So
that's a really good point.
Comfortable with a week.
Yeah, we have a proton clinic here as well. And when we start triaging our proton patients of who needs to be treated on photons, prostate's almost always last. It's your head and necks, it's your lung cancers, and then you get in, obviously P's are going to be high up on that list or first on that list. But then you get into your breast cancers, maybe at that second wave. Prostate is universally last in our clinic. All right, I'm going to jump into dose distribution. Starting with prescription normalization, verify plan prescription normalization methods are appropriate. So do each of the prescription levels match what's in your directive? Are we getting the right amount of dose to the right tissue? And is there minimal limited plan normalization? So as I was trained, ideally, you are controlling, especially when you get into the SIB world, where every plan may have multiple different dose levels and multiple different OARs. A gross normalization of just increasing the whole plan MU up or down by, if it's more than 1%, was heavily frowned upon. We wanted to control the dose in terms of how much it was pushing each structure within the optimization itself. In 3D planning, normalization makes a lot more sense. And even in sequential planning, where it's one dose level per plan, it can make more sense as you're raising that dose up and down. But we typically avoid normalization as much as possible, especially within the SIB world. And our rule of thumb is if it's more than typically 1% of normalization, run it through the optimizer again to try to shape. Because if you're normalizing it, you may win in the one area. Let's say it's your high dose target, dose your high dose target. You may increase it to get that up, but then you lose somewhere else. And we want to try to avoid that. Algorithm and dose grid. Verify that dose calculation algorithm and grid size are appropriate. As I mentioned before, for SBRT, you typically want, I mentioned this before for related to contour resolution, but the same thing applies for dose grid resolution, is higher resolution calculation grid size. So we may go down to, if we're using 2 millimeter slice thicknesses, we may do 2 millimeter grid size versus 2.5 or 3 millimeter for the calculation. We typically don't go to 1 millimeter except for our SRS plans because these volumes are bigger. And so that resolution down to 1 millimeter may be not beneficial given the calculation impacts. The algorithm should utilize institutional standards. Are you using something that is Monte Carlo? Or using something that maybe is less susceptible because we're in the prostate versus where you have higher tissue heterogeneity? So something like AAA, those may be perfectly acceptable, but there should be institutional standards of what you're using. And then understanding the specifics of each algorithm. And we have this is not within the scope of this talk. You could have a whole lecture series on algorithms themselves and which one does what. But as a physicist, it is inherently our job to understand those algorithms and what could be the consequences of one versus the other when we're in the treatment planning world. Target coverage and conformity. Again, review target dose conformity and coverage, including the use of any quantitative metrics when possible. So for instance, I like to look at both prescription, so the volume getting prescription, and the volume getting 95% of prescription. From in the prostate world, at least, when I'm looking at V100, likely doesn't cover the full target and may undercover, especially in overlap with critical OARs. I have a next slide to show this. And then, but V95, so 95% of prescription should cover most, if not all of that target. And then looking at conformity, not just at the prescription dose level, but at lower dose levels, low and mid, to look to see is the dose bulging in areas and directions that I expect it to, and it may be bulging more around higher dose targets. So visual example of what I'm talking about. Here we're treating prostate bed, we're in green, and then in red are these boosts within the bed itself. If I turn on 100%, so a low dose target is getting 6250. So the green is getting 6250. The high dose is going to 6750. Up here, you can see that high dose, the edge of the color wash here represents in the top right corner, the prescription of the high dose target. So we're well covering the high dose targets. If I put on directly underneath it, my prescription dose level of the low dose target, so 6250. A few things I note. I'm undercovering a little bit in that overlap here, which is with the rectum. Well, that makes sense because the optimizer says lower rectal dose as well as getting target coverage. It's trying to split the difference. I'm undercovering a little bit in the overlap with the bladder, a little bit over here. I think that was more beam angle driven. But also note that my prescription is bulging out right down here because that's right next to the high dose target. If I put on 95% of my low dose is 5937. I'm covering pretty much my full target itself, but it is bulging more. So this makes sense, right? I'm where my dose is cold, or maybe it's a little bit hot relative to each dose level of the targets. I need to have an understanding of what that looks like or what I expect it to look like. And as you build up through this understanding in the back of your head, if something's different than you're expecting it to, that's a great reason to pause and investigate. Maybe, oh, why is my dose not bulging out close to my high dose target? Or maybe it's bulging out somewhere that there is no high dose target. What's causing that? Those are good questions to ask as a physicist. Hotspots. So review the magnitude and location of the hotspot and high dose streaking. So where is my hotspot for the plan? Is there high dose streaking outside of my target? Hotspots, which is I define it as dose at or above prescription, should all be within the PTVs. Standard anatomy often contains hotspots. So atypical planning anatomy may result in odd dose distributions. And I have a visual example of that as well. So here is a very challenging case that we ran into. This is treating not just prostate, but bladder as well. So prostate, bladder, nodal chain. There were Unfortunately, that didn't work out perfectly well, but there are 3 different dose levels. This is going to 30 fractions. So 6450 was the prostate, the boosted nodes, which is basically what you can kind of see here in pink. So the boosted nodes plus prostate, all of that going to 6450. 54 gray was that volume plus the bladder. I don't have that turned on, but that will be light blue. And 51 gray is the pelvic nodes. That'll be dark blue. So it looks something like this. This is atypical anatomy. As soon as you get into atypical target anatomy, now you're in the realm of something weird can happen, because if we apply the same optimization rules, we may not get the desired dose distribution. So I spend a lot more time looking at these types of plans. So just kind of step through, that is our high dose target. Here you can see the mid dose target going to 54, where it's now extending into where the bladder could be. And then there's the low dose target, including the nodal chain. So all of these together, and it's SIB. So this is super fun. I love these types of plans. They're very challenging, but this is where it really is important to apply our skills. So what happened here? Well, when I turned on the hotspots, so recall that my prescription dose to the pink is 6450, but I turned on 64 gray. That's what we're seeing on the left here. I was getting basically no prescription to this at this particular axial slice, no high dose prescription to this part of the target. And I was getting kind of a sliver here on this side. And the reason for that is 6450 was above my bowel dose. So because I have small bowel here, effectively it was overlapping that target. I was saying, hey, I can't achieve both prescription coverage and preserve the bowel. You told me the bowel was a constraint. I'm going to make sure I get that. So that made sense to me, but I really didn't love when I turned on 58 gray. So note, 58 gray is 4 gray above our mid-dose level prescription. When I turn on 58 gray, that pretty much well covered my targets on the patient left, but on the patient right, it still wasn't in target and it was bulging out into the bone here. So I'm getting way above prescription, almost 10% above that mid-dose level prescription, and it's nowhere near my target. So to zoom in on that a little bit, what's going on here? Well, the dosimetrist made op structures. So these are op structures for targets that are not just excluding the high dose target from the low dose target, but also effectively excluding the higher important OAR, which in this case is bowel, from that target and retracting it. So what they did was they took the PTV 6450, the pink one, and they excluded bowel, small bowel plus a centimeter, because the dose limit to that small bowel was 50 gray. So the prescription was 14.5 gray above the dose limit. And the rule of thumb was, okay, take that bowel plus a centimeter, retract it. What that ended up causing on the patient left was a decently sized, you can kind of see it highlighted here and here, decently sized op structure. That's reasonable. On the patient right, it was this little sliver, just that tiny little sliver. And that's a hard thing for the optimizer to push dose to. And so what it was ended up doing was it was pushing dose adjacent to it and letting the scatter kind of carry it into that part of the structure. There's other things going on here that I could spend 10 minutes talking about. I won't. But as a dose distribution, this is not ideal. Our hotspot is way outside the target. It is not helping at all really cover the actual CTV, is barely covering the peripheral, the PTV, which is not the tissue we want to get to. So that is the example. We ended up cleaning it up. I don't think I have a slide on that. I can talk about that maybe while you answer the next question, because the next question is our second poll question. I'll read it. When reviewing a treatment plan prior to treatment, which of the following should not be considered for the dose distribution? Again, not. Conformity of prescription to the target, dose fall off outside the target, hot spot outside the target, or uniformity of dose to organs at risk.
Okay, I launched the poll and we'll give you a minute or two to get your answers in.
So on this last case, I don't think I have the slide to show how we cleaned it up, but effectively we took that patient right-sided high dose that we weren't achieving anyway, And we said, okay, well, we can't achieve that 6450 to that. Let's try to get 58 gray to it, still retracting it, but giving it a reasonable opt volume to push dose to. And that eliminated the hot spot outside.
All right, we'll wait a couple more seconds to get your answers in.
All right. So the answer is number 4. If I can make it scroll. Oh, I do have a slide. Perfect. Sorry, I'm all over the place. There we go. We do care about the conformity of the prescription to the target. We do care about dose fall off outside the target. We talked about how maybe higher gradients in certain directions are more preferable if it's a higher priority OER. We do care about hotspots outside the target. Typically, we don't care too much about uniformity of dose to organs at risk. We actually almost always want a non-uniform dose to organs at risk because it's going to have a higher dose closer to targets and a lower dose further away. All right, my mouse has stopped scrolling. There we go. All right, we'll talk about some more on the dose gradients. So when you're looking at, and this kind of falls also into just general dose distribution as well. But I'm a color wash. A lot of people love isodose lines. I struggle with isodose lines. So I like to look at color wash, and I'll look at high dose, mid dose, and low dose levels of color wash and kind of extend that out. But you want to look at, that gives you a sense of dose gradient. So review high, medium, low dose levels with expected gradients in mind. So those dose levels should be closer together in regions of high dose gradient, further apart otherwise. For prostate SBRT, high dose gradients are desired, and you want to fall off as fast as possible. Dose gradients should be maximized, again, in direction of high priority OERs, lower dose gradients in the direction of undefined normal tissue or lower priority OERs. OER sparing, you want to confirm that organs at risk are spared as much as possible in order of clinical priority. That's what's specified in your MD directive. Variable based on target anatomy and also OER anatomy. So with prostate, it's interesting. There's some variation in prostate volume, but it's not huge variation compared to other sites. Lung, obviously, is a great example. Breast can be another one where the target itself can have a huge variation. Here, our targets typically have a moderate amount of variation in sort of OARs, full bladder, empty bladder, full rectum, empty rectum, and that can have an impact on the doses to those OARs. Often experience is driven that qualifies what maximum OER sparing is. So prioritize again those high priority goals. This also may be time limited in achieving OER sparing. So dosimetrists, if you give your dosimetrist 2 weeks to plan, they can make the perfect plan. Our clinic, they get a day to plan, maybe half a day. And so there can be some limits in there, and having a systematic way of approaching planning is really key to maximizing that efficiency. You can be assisted by some dose prediction tools, such as RapidPlan is one example, although there's many examples, a growing number out there that give you some sense of what is achievable based on that individual patient's anatomy. All right, so I want to give an example of improved OER sparing. It's a little bit of a background here. This is a prostate and nodal SIB that we treat in our clinic prior to using standard planning procedures. So you can see the prostate itself is down here. That's surrounded by that nice high dose color wash red section. And you have the nodal chain here and a fair amount of spillage into the bladder itself. So this plan was actually treated clinically, but organs at risk are not spared adequately. And going back and looking at what was happening, we just really didn't have a standard approach on, number one, using the in and out structures. Number two, what types of metrics we should be putting in the optimizer for the OARs. And then number three, it was just also experience of dosimetry of how far they should push a plan. And so while it met because it's a very large bladder, it met all of the metrics, it was not as good or optimal a plan as we could have otherwise achieved. So going back and replanning it, using standardized methods that are taught in RCC courses, we had significant improvement in the sparing of organs. I'll flip back and forth a little bit. So again, there's some magnification changes between, but you can really see the edge of the color wash is the same here, and it's pulling the dose out of the bladder pretty entirely, while also sparing rectum as well. DVH metrics, so close, there's only a few slides left. Review DVH metrics, relevant clinical goals, in the context of both national and institutional normal tissue dosimetric goals. So There's a lot out there. You have national goals, whether it's Quantec, whether it's individual trials that are replacing Quantec, which is a little bit dated at this point. So you want to be comparing against those standards, but also your institutional standards. You may have your own physicians that have had clinical trials that they've run or that they have been reviewing in the literature that may not be standard of care, maybe earlier in the implementation than standard of care across the field, but they have a lot of faith in. And those should be specified. And so here's an example where we have bladder, rectum, small bowel, femoral heads, penile bulb, and there's two different plans here, but you can see here's the metric for dose, so V58 gray or 5800 centigray, the range of volume that's acceptable, and then you can also compare a couple of plans if this is set up with the software that allows for it, and get the sense of, oh, do both of these plans meet those metrics? Great. Maybe you move on to the next metric. Here's a great example where you have bladder at 33 gray. For plan 1, we're exceeding that. Plan 2 is not. And then it flips for the next metric of rectum, where the rectal dose is exceeding some limit. So this gives you the ability to compare not only against whatever standards you've used, but between plans themselves, and maybe hone in on one plan that's a little bit better. Obviously, this should not be exclusive to dose review as well. So DVH, highly important. Making sure you're looking at dose metrics, dose distributions, also highly important. You can be looking here, plan 2 is significantly spared, dose to several OERs. And if you look at this one, it only increased by about a gray on that max dose. And that may be acceptable for that particular physician. Excuse me. And then finally, closing out with composite with prior radiation therapy. We mentioned this way at the beginning, but we're seeing more and more of this, which is something that we need to start accounting for. As a standard, this is where it's really challenging in our field. It's very, very specific to individual patients based on how much dose they previously got, how long ago it was, were there multiple courses, how much does the anatomy change, what's our goals for this dose distribution. So it's very difficult to come up with any set standards. And so we start looking at, we do BED calculations, maybe with or without any time allotment to account for the distribution or displacement from previous treatment. And then make your best guess. And that's working with your physician. They'll largely drive it. We aim for, well, it depends on the physician, but we typically aim for safety as best we can while trying to get dose to help our patients as best we can. So confirm where that prior radiation was. This is our responsibility, making sure that the physicians have accurate information so that they can make those decisions. So you're verifying the composite plan considers biologic dose when possible. Sometimes that's in the plan review itself. Sometimes that's just pulling the relevant DVH metrics and using some way to combine them into BED to get an actual number that the physician can use. Looking at sequentially delivered plans, you're evaluating target coverages on individual plans. So this is a little bit different, but this also can be, this isn't under the paradigm of prior radiation, meaning prior in the same course or maybe a separate course delivered very recently. But as a general rule of thumb, I'm looking at my target coverages. If I'm combining multiple plans that are sequential or looking at historic records, my target coverages I'm looking at on the individual plan, but the OER metrics I want to look at on the composite plan. Maybe there's some maybe caveats to that, but that's a general rule of thumb. All right. All right, I'm going to jump through the last 3 or 4 slides here and then open it for questions at the end. So communication, this is a pretty standard language. I think you've seen in others as well, but it has its own slide for a reason. And this is, treatment planning is complex. This is 30 years ago, you had physicians that would be at the sim, they would do their field placement, they would calc the plan and they would move on and they would do all of it. And our physicists would be double checking. Now it's, 6 different teams of people at some clinics, or at least 3 at most, therapy, 4, therapy, physician, dosimetry, physicists that have different roles that are evaluating different things. They may have different things that are prioritizing their review. So communication by far is the most important thing as we're passing information between these groups. So are we confirming that necessary information is to the right people at the right time and that it meets what we need to do our job? to ensure that the best quality plan can be delivered to the patient. This can have a lot of flavors. So requirements of pre-treatment imaging is a great example. Multiple isocenters, which may impact different mobilization, and that could be challenging. So maybe different scans because we want to have the anatomy in different positions. Unstable anatomy, regions that are blocked in the plan, such as if we want to avoid coming through hip, if you're in a clinic that wants to avoid coming through a hip implant, okay, well then we have specific gantry angles that we're going to avoid. Isos lines were high gradients of note. We're talking about image registrations. There's probably 100 other things that are important to communicate. So having those communication lines, whether it's direct, if you're in a small clinic, sometimes you just knock on your colleague's door and talk about it. If you're in a big clinic, having some method by which the appropriate information can be found quickly and efficiently is critical. And then incident learning to kind of close out. Things go wrong, and they go wrong all the time. We have at our institution a homegrown, we call it SAILS, but it is an incident learning system in which we will put in anything that deviated and use that information to figure out, is it a standard of practice issue? Are we changing somewhere upstream that has unintended consequences downstream, whether it's communication or how we have changed planning, whether it's someone that's new that hasn't been appropriately trained in something and we saw some pattern there, or whether it's something more severe. But some mechanism by which to evaluate when things go wrong. And then also, and gosh, I could have a whole lecture on just incident learning systems and how important they are, but that this is useful. This is not intended to be blame casting. It's super important to make our processes better as we get more and more complex. So that was the last slide. I will close there. I'm going to keep slides up just in case there's questions related to something in particular, but I want to open it to everyone one last time.
Thank you. That was so great. We did have one question about the expected gradient index or fall off that you expect for prostate SBRT.
Ooh, that's a great question. I don't have off the top of my head. I'd have to look it up because I don't have a good rule of thumb that I use in the photon world. And that's partially because we still are obviously controlling for bladder or rectum first, then bladder. Yeah, I'd have to get back to you on that one. I don't want to even give you a number that's just grossly wrong because I don't have an intuition there.
I felt the same.
I will say that our physicians tend to not use gradient index metrics. They tend to look at isodose distributions. The challenge with that is it requires experience. You're building up, you have to see a bunch of these plans to know what is reasonable versus a number that we could give you and be like, hey, this is the number. And then you could use that as a metric. But they use the isodose is because it is not a uniform index in all directions. It is still bulging a little bit laterally versus an ant post. And so a number is useful, but it can mask certain nuances in the individual plan. So our physicians don't typically use that to the point where it's not even part of their directive. And so as a group, we don't use that as well, but we do spend quite a bit of time just getting familiar with what these should look like.